we just saw. And now we move on with the next session of the day. It will be on TAVI, and the chairpersons of the session are Dr. Prakash Hajra, Dr. Rajneesh Kapoor, Dr. Anjanal Datta, Dr. Rupdas Viswas. The moderator of the session is Dr. Ashok Seth. The expert panels are the Dr. Imran Ahmed, Dr. Gautam Datta, and Dr. Jayanto Saha. Now, I request the chairpersons and moderator to take over the proceedings.
So hello everyone, can you hear me? Indeed,
Yes.
a pleasure to be at the Econ 2021 organized by the CSI West Bengal chapter. And we have a great session ahead. I hope the panelists as well as the chairpersons are in position, because we'll try and stick to time and have some very good discussion from the experts who are going to talk to us about the nuances and the step-by-step for transcatheter aortic valve replacement. So our first talk is going to be by Dr. Robin Chakravarti on the spreading pool of TAVR. Over to you, Robin.
Thank you. So good evening to everybody, and we are going to start the session straight away. And so I'm going to talk to all of you on this spreading pool of TAVR. Basically means the indications, and TAVR is progressively becoming very important intervention for severe aortic stenosis. And we need to also recognize that this 21st century has actually a cardiovascular intervention revolution. There are disruptive technologies, evolution, the guideline changing therapies, and more so towards a structural revolution. But how did we get to where we are with TAVR today? And that is what probably I'm going to start. Today we have got rigorous clinical evaluation from many randomized trials against gold standard therapy in the United States alone, with over 6,000 patients demonstrating equivalence, superiority over standard therapy. Multiple other trials evaluating different devices in severe aortic stenosis as well as new indications. Trials are designed to show equivalence to surgical replacement of the aortic valve, and also perhaps about the superiority. And also they are also looking at various endpoints which are important for clinicians. We are clear that today the current indicators are for those patients who get significant benefit are in native valves, severe, symptomatic, and of course in valve-in valve. We have got data to substantiate this statement by randomized trial data and observational data. We also have future studies and indications and next frontier to apply this technology more and more for our patients' care. We know that there are potential advantages of TAVR in terms of less invasive, lower risk of bleeding, shorter length of stay and recovery, similar rates of mortality. We've got evidence to support that. We also have, we had some concerns earlier about paravalvular risk, particularly about low risk patients, because the concern was that whether TAVR can be used in severe aortic stenosis with low surgical risk group of patients. But the concern was this patient, there are evidence of paravalvular leak and pacemaker risk, which may actually tilt the balance towards the surgical side. Also, there is a question about valve performance and longevity. Perhaps in this group of patients, we need to have another sort of replacement in about 10 years' time or something beyond that. They also had anatomical consideration like bicuspid aortic valve and young patients who are likely to have more multiple replacement. But with time and with advancement of technology, advancement of valve size, and also the device delivery system, there are changes. At the same time, as we have more and more evidence, there are changes in device evolution. New generation devices are safer and perhaps more effective. of less pacemaker requirement and less paravalvular leaks, perhaps mild paravalvular leak, which may not have much of hemodynamic significance. Smaller profile and sheet size from the delivery of this device point of view. If you look at the LRT study objective, which assessed the safety and feasibility of transcatheter aortic valve replacement with commercial in patients with symptomatic severe aortic stenosis with low surgical risk of less than 3%, then they realized that in a month, there's no mortality. And if you continued for a relatively longer period of time, and the data is quite substantial to support that probably yes, in what is called mild symptomatic group of patient or mild risk group of patient, it can be used. Substantially presented in various meetings. We also know that the valve-in-valve is an important therapy for patients at high or extreme risk of redo surgical aortic valve replacement, because this important therapy for patients at high or extreme risk for redo surgical AVR is important. It is safe, effective, and in a select group of patients, it's very useful. Although the durability is unknown, new techniques are developed to overcome potential drawbacks. Asymptomatic patients, we don't know. We got a trial called early TAVR is going through. We need to wait to get the results. Of use of TAVR in pure native valve aortic regurgitation. I'm sure that the next speakers and the moderator and the chairpersons guide the audience toward these new frontiers of use of TAVR. Now, this is a very important slide presented 2 years ago, less than 2 years ago, actually, in European Heart Journal. And it has been shown that if you consider the all-risk group, high-risk surgical group from 1A trial, and also the intermediate risk group of TAVI and partner 2A trial, and low-risk group from NOTION trials, if you collect all these data and then plot them together, it has been clearly shown that over a period of 2 years, there is a significant improvement of the survival, which indicates that 12% decrease in mortality if you take all these groups together, which is extremely useful information. And based on this paper, FDA expands the indication of severe transcatheter heart valves to patients at low surgical risk for death or major complications associated with open heart surgery. So clearly, we are moving from high risk group to low risk group in severe symptomatic aortic stenosis. So earlier, probably in 2012 or maybe 2013, 14, probably the surgery was the gold standard of aortic stenosis. It has been remained as a gold standard for years and years together. And alternative option used to be TAVR. But if you look at the data, like with the change of our understanding, recognition, and at the same time of valve technology, and also decrease of the sheath compatibility from 22 French till 14 French of the availability of the valve size from 23 millimeter to 29 millimeter today. Evolution today, perhaps we need to consider, we need to talk about that TAVR could be the first scenario. So today, whether or not the TAVR could be gold standard and alternative and optional could be. So there is a clear paradigm shift of understanding of management of severe aortic stenosis, especially in symptomatic group. So therefore, based on the data, there is another thing, the same journal, it has been published that it has been revisited, that if you have a patient of severe symptomatic aortic stenosis with low surgical risk who do not require concomitant cardiac, there is no contraindication for TAVR, then probably you can go straight for TAVR. If you have some patients with lot of difficult trans-femoral access, age is more than 60, valve, then probably you can also think of TAVR in this group of patients. Of course, in some patients who require multiple valve surgery or maybe a very complex coronary vascular surgery or arrhythmia surgery along with bypass surgery, then they probably can go for surgical replacement of the aortic valve. And in this data, again, the transcatheter aortic valve replacement with surgical valve replacement comparison, you look at all the parameters like all-cause mortality, cardiovascular mortality, neurological event like disabling stroke, and all-cause death and disabling stroke. Clearly, in a month's time and in a year's time, the TAVR is much ahead of surgery. You can see this is data which is very, very promising and appealing to interventional community. So this data from the replacement, transcatheter replacement in intermediate risk group, which is a balloon expandable valve group, clearly it has shown the improvement. If you look at the two graft surgery and TAVR, it has been shown that death and stroke is clearly superior in TAVR group of patients. Similarly, if you take a balloon expand or a self-expandable aortic valve, again, the same surgery and TAVR, probably there is not much of difference between death as well as the stroke. Therefore, if you look at even the transcatheter aortic valve replacement with balloon expandable valve in low risk group, if you look at all these manuscripts, they clearly indicate that TAVR could be a clear option, a better option even in low risk group of patients. Therefore, the great data, from Martin Leon and Sushil Kodali's group has shown, even we are talking about paravalvular regurgitation in low risk group of patients. If you look at this slide, clearly shows the paravalvular significance. It is very minuscule. There may be a mild paravalvular regurgitation which doesn't have much hemodynamic significance. Therefore, and if you at the same time in the low risk group of patients, if you compare the bleeding risk, life-threatening risk, major vascular complication, acute kidney injury, and pacemaker indication, all these kind of things, even new LP, this kind of thing is much superior in TAVR in a year, in a month, and perhaps beyond that. And same is true with the self-expanding valve. The other one was true for balloon expandable valve. This is self-expanding valve. So to take into all this consideration, it reminds me a great quotation by Professor Eugene Braunwald, that two separate groups using two separate valves have come to a very similar conclusion. This not only doubles the acceptability, but it quadruples the acceptability. The TAVR is a standard of care for majority of aortic stenosis patients, and I'm sure that we can say that. So the TAVR is superior in terms of low atrial fibrillation, quick recovery, and better hemodynamics. So, and if you look at that, again in valvular valve, it is progressively coming up. It is a useful tool, TAVR. When people are reacting to aortic valve in a reverse crimp fashion, they crimp the valve and try to use it across the mitral valve in valvular valve position. In bicuspid valve, again, the new literature is coming up. It is difficult. There is asymmetry, the large annulus, there could be aortic pathology, there could be more calcium. Despite all these limitations, now people succeeded to use it in bicuspid aortic stenosis. We have to wait to get the data of TAVR unload and early TAVR in terms of whether or not it can be used in patients with reduced ejection fraction, with intermediate risk, and asymptomatic group of severe for these data. So to summarize, and this is a nice one. So I remember that it was presented earlier in 2012, and they said that probably in 2025 the number is going to increase significantly. 200,000, and in probably another 5 years, it's going to be 300,000. So it is important. Therefore, knew sometime like 60 years ago that severe aortic stenosis, if the patient becomes symptomatic, this is the natural history.
Hello. Dilip is.
I think we have lost Dr.
That's right. I think it's his connection.
Yeah, I know the last.
So I think he's here, but he's back, and I think we may have a.
Ravin is back. Yeah.
Couple of minutes. Sanjan, any questions or comments on his talk? Can I just ask you?
I have only a small comment or question to make. Whether calcium load or bradycardia, these two factors have any prognostic indication and importance?
I think maybe we can talk about all this later on. Ashok, what do you
Yeah, I think we can, but
collect
I
all this
think
data
I
and
think
talk?
I
Lot
think
of
that
questions maybe overlap.
sure, but I think one thing which will actually have to be addressed here, and it's a great talk, Robin, is that we cannot assume that low-risk patients means younger patients. I think they're two different subgroup of patients.
Yeah.
We must also remember that you could actually have a 60-year-old who's a low-risk patient, but is not synonymous with the same data, because that was a mean age of 72. When we look at 60, we can look at 59, we can look at 60-year-olds. We have to define their path for them over a 20 to 30-year period, rather than a 72-year-old who's low risk, whose path has to be defined perhaps on a 15-year horizon. And that is why if we do expect two procedures to happen in a patient over his remaining lifetime, we have to think through and take a considered decision, including an informed decision where he realizes what are the limitations of having a transcatheter valve too early in life, even though it may be low risk. That's something which I'd like to convey. We must remember that the mean age in low risk trials was 73 years and not 65 years and not 60 years. So I would now take I would now move ahead to the next talk. The next talk is by Dr. Lars Sondergaard. Dr. Lars Sondergaard is a world-renowned master interventionalist from Copenhagen in Denmark. He's a professor of cardiology. He's not just a TAVR specialist. He's a scientist par excellence. He's perhaps an investigator of most valves that we use at the present moment and all the new devices. He's a thought leader. He's published, his citations go to 14,000. He's published more than 450 manuscripts.
Well selection, Dr. Praveen Chandra. No?
Truly is a pleasure to have Lars talking about step-by-step TAVR.
Thank you for the very kind introduction, Asak. So yes, we'll try to talk about step by step here. So first of all, we know that what's very important to have a successful outcome is to have good pre-procedural planning. And nowadays, all the patients we are treating with TAVI is undergoing a CT scan before, both a cardiac ECG-gated CT scan and also a non-gated CT scan for looking for access vessel. And what we're looking at is, of course, the anatomy of the aortic valve. Is it a tricuspid valve? Is it a bicuspid aortic valve? What is the calcium distribution? And also, of course, what size is the annulus? What size valve do we need to choose for each specific patient? We're also going to look for the risk of complication. Again, as I said before, not only calcium at the aortic valve, but also if the calcium is extending down to the left ventricular outflow tract, because that will increase the risk of not only paravalvular leak, but also the risk of annulus rupture if we are too aggressive with the balloon used for pre or post dilatation. Another fear complication is occlusion of the coronary arteries. So we want to see that both the sinus of valva are wide, but also that the takeoff of the coronaries is high, at least 10 millimeter. And you see the one on the left-hand side have a high takeoff, the other one have a very low takeoff, and you should have concern this could be lead to a coronary occlusion, which of course potentially is a fatal complication. We also need to introduce these large core systems. And most systems have an aorta profile between 6 and 8 millimeter. And they need to go in to the valve. So if you have a hostile aortic arch, as in this case with acute angulation, be concerned that this can lead to vascular complications. And of course, we want to treat as many patients as possible by a trans-femoral approach. So we need to look at the access vessel. What is the size of the access vessel? What is the calcium burden? And how tortuous are they? So again, you see two examples. One is very suitable for a transfemoral approach on the left-hand side, and the one on the right-hand side is not suitable for a transfemoral approach. You have to look for alternative access for this patient. And again, when we started this program years back, the most common complication and the complication who was the most common cause of mortality was complication at the access side. We want to puncture or access the vessel somewhere between the ligaments and the bifurcation of the common femoral artery. And the reason we want to be above the bifurcation is that if you have vascular complication, we want to be able to treat it with a covered stent. So we need to puncture a 1 or 2 centimeter above the bifurcation. And there's two ways to do it. Most sites will nowadays do a fully percutaneously approach using pre-closed devices such as the ProGlide, including 2 ProGlide system here, which will leave 2 sutures which can be tied afterwards to close the vessel. But also, if you don't have the experience, it's still possible, of course, to do a surgical cut down and then make an insertion in the common femoral artery and use that for introduction of the valve. If you do a percutaneously approach, it's of course important we know exactly where we are puncturing, again, between the ligaments and the bifurcation of the common femoral artery. So most often people will cross over from the contralateral artery, have a 6-strand sheet, go up to the bifurcation and down to the ipsilateral side. Do an injection here and use that to navigate for where you're going to puncture the artery. More and more sites are now also moving away from this. They're using ultrasound guidance. First of all, because it's safe radiation, particularly to the operator who's standing very close to the C-arm during this, but also that it has allowed you to have a more precise puncture of the middle of the vessel and a spot of the vessel where you have no calcium, because that's going to increase your chance that your closure system is going to work successfully. After you have a puncture, you put a 6-strand sheet in. You go up with a standard catheter to the descending aorta. You exchange for a stiff guidewire, often an Amplatzer super stiff guidewire, but there's also pre-shed wires such as the Sapphire guidewire or the Confida guidewire. With that in place, you exchange the 6-strand sheet for often a 10 and 12-strand sheet before you introduce your delivery sheets, which is often around 18 strands. Also, as I said just before, it's important to have all your bailout tools ready. So when you have done your procedure, you remove your sheet, have a crossover again before you remove it, do an injection. And if you see there's major vascular complication, you need to be ready to handle it. Using a balloon inflation, or if you have a severe vascular complication, as in this case, implant a covered stent. And you see again, this is the reason why we want to puncture a few centimeters above the bifurcation, proximal to the bifurcation, not to occlude the profunda artery during the stenting. So what about the transcatheter heart valve implantation itself? So when we are in place, we place from the contralateral side a pigtail in the bottom of the non-coronary cusp. That's going to define where is the aortic annulus. And we're going to choose a C-arm projection where you have the 3 aortic cusp aligned. So you have a better understanding where you're actually implanting. So with that pigtail in the bottom of the non-coronary cusp, you know this is where the annulus is defined, and you want to implant often a few millimeters below that. First, you need to cross the aortic valve. Most sites will use an Amplatzer left 1 or 2 diagnostic catheter and a straight guidewire. It can be a standard guidewire, which is going to give you a little bit more support, but you can also use a hydrophilic wire, such as a Terumo wire. So when you're across the valve with your wire, you push your catheter forward, you remove the straight wire, you introduce a double-length standard J-tip guidewire, and then you introduce a pigtail catheter. The pigtail catheter is used both for hemodynamic measurements before valve implantation, because that's going to be useful when you're going to afterwards to assess for paravalvular leak, to measure the end diastolic pressure in the aorta and in the left ventricle and the diastolic pressure in the aorta. Afterwards, you have to introduce your guide wire. As I said before, you can have pre-shed wire. Medtronic is having the Confida wire. Boston Scientific have the Sapphire wire, but you can also just shape it yourself. having a plastic tube, and then just very gentle, not force too much on it because that can peel off the coverage, but just do that, and then you can make a pre-shaped wire yourself, a shaped wire yourself. With the wire in place, if there's a lot of calcium, particularly for self-expanding technology, most operator will do a balloon dilatation using a balloon which is not exceeding the minor axis of the aortic valve as measured on the CT scan. And the reason why we are not too aggressive is that it's always a balance between opening up the calcium and also, of course, avoid annulus rupture of the patient. After the balloon dilatation, you choose your valve. What I favor is self-expanding technology because it's going to give you far the best hemodynamic afterwards. And very recently, last year, the Hydra valve was launched in India. It's an Indian valve, which is try to optimize all the shortcoming of existing valves. So it's a very flexible system, will take very tortuous anatomy. Large stent cells will facilitate easy access to the coronaries. It got supraannular leaflet position, which is going to give you, as I said before, far the best hemodynamic outcome. And also you see the inflow part is not tapered, it's straight cylindric. So there will be very little interference with the conduction system and thereby reduce the risk of new conduction abnormality. And of course, you need to know your valve. What is your landing point? And this valve got two sets of 3 markers here, one here, down here, and one further up here. And what we're going to aim for is that these markers should just be above the annulus level, where we have the pigtail. That's where we want to implant the valve. So use that for navigation. So you can see here now the valve is across the aortic annulus. You have the pigtail in the non-coronary arteries. You have one set of markers here and another one up here. You use the bottom one, and the marker should be just above the pigtail when you start to deploy. And if the position changes during the deployment, you do adjustments. And again, it's a very simple hand. You just have a blue knob here. You're going to do counterclockwise rotation. That's going to lead to unsheathing here of the device very slowly. So you have time to correct and optimize the position. And it's also illustrated here that the valve is slowly coming out. You can pause at any time here and adjust the position. You don't need to go very fast as for the balloon expandable valves where you have one shot. There's 3 phases. The first phase, you go very slowly on the knob. When you have annulus contact, there will be partly obstruction. You start pacing, not particularly fast, 100 to 130 beats per second. Go a little bit faster through this part. And then you pause again, assess it. And if you're not happy, you can actually recapture the valve and reposition, start all over again. So very forgiving. So this is just one scene loop here of the deployment. You see the curved stiff guidewire in the LV. You see the nose cone. You see the stent frame. And also you see this radiopack marker at the end of the capsule. So as there's rotation on this blue knob, then the capsule will slowly come back, and you can do small injection with your pigtail in the non-coronary cusp. 10 cc at a rate of 20 cc per second is what I'm using, just to have an idea where are you. And that's going to allow this slowly expansion here, that you all the time have control exactly where is the implant during it. And again, it's a 3-phase. The first part, you go very slowly up to you have annulus contact both on the non-coronary and the left coronary side. Then you go a little bit faster during the middle part of it. Still have time to pause. And again, as I said before, if you're not happy about the position, you cannot adjust it. Just recapture it and change the position and start all over again. When you come to the last part here, and you have to again to make a decision, are you happy about the position? And if you're happy, you just continue, and the valve will slowly be released from your delivery system. So again, a very controlled deployment of this valve, which is very different from what you see with the balloon expandable valve, where you have to go very fast with the inflation. Before you do your fine deployment, often we'll remove the pigtail catheter and then go up. You see now the radiopack ring is approaching where this valve frame is attached to the delivery system. There's 3 tentacles. And as it passes those 3 tentacles, they'll just jump out of the delivery catheter, and then you have a full valve deployment. Afterwards, you have to assess for paravalvular leak. There's 3 ways to do it. You can do an echocardiography. Since most sites are now treating the patient under local anesthesia, it's difficult to do a transesophageal echo, but you can do a transthoracic echo. You can do an aortic root injection to look for how much contrast that will be leaking back. And again, with a pigtail in the aorta and a pigtail in the LV, you can also have hemodynamic assessment. So what you want to see is a good separations between the diastolic pressure in the aorta and the end-diastolic pressure in the left ventricle. If you don't have that, that's a sign of paravalvular leak. The most common reason you have it is you have very calcified aortic annulus and the stent frame is not fully expanded. What you do is you take a balloon, which should not exceed the mean diameter of the aortic annulus as measured on the CT scan. You do fast rate pacing, you inflate the balloon for 1 or 2 seconds, deflate it, stop pacing, and then it will often solve the problem about paravalvular leak. I'm just going to show here the final slide. This is from the Genesis trial in India, which led to approval of this valve last year in India. You see, once again, self-expanding technology with supine leaflet position is going to give you the far the best hemodynamic, the very large opening area, more than 2 square centimeters, and 1-digit mean gradient, much better than what you're going to see with balloon expandable valve. And also with this valve, you see that the rate of paravalvular leak is very little. When the patient came back here at 30 days, 97% of the patient had none or trace paravalvular leak, and the remaining patient had only mild PVL. So no patient with more than mild PVL. And also very important, one of the issues if you're going to expand to younger patients, what is the risk of conductance abnormality? And in this study, only 7.5% of the patient had a new permanent pacemaker. And all patient was pacemaker naive before the valve implantation. So with this, I'm going to finish my talk and will be happy to answer any questions.
Sir, you have to unmute yourself, Dr. Shade.
So Lars, that was a tremendous talk. We realize that it's extremely difficult to cover this vast topic, but you still did an efficient job of actually conveying every aspect of both the technique as well as the precautions to be taken to get the best results. I have a question for you, and I'm sure the audience would like to understand. There are many interventionalists out there, and while some may not be doing TAVR, all have sometimes need to cross the aortic valve or a stenosed aortic valve for some reason, including pressure gradient measurements. And it's a technique that everybody would want to understand a bit more. Do you have any tips and tricks or any special methods that you use to cross a stenosed aortic valve? Or is it just keep trying till you get the wire across? Is there a science or is there an art to it? Yeah,
I think it's certainly something you can learn, and you know that, Asok. If you have in the beginning, it's difficult, but when you have done it quite a few times, it's often not that difficult. So I often use an Implantation left 1 catheter. If it's a little bit more horizontal, also where you have a more vertical position of the valve, I will maybe take an AL2 catheter, which is going to lift you up. The closer you go to the valve, the more will the valve point upwards. So you can adjust the position. And if you for example, an LAO cranial projection, if you just do a scene, you will often can see the calcium, and you can see where is the opening between the calcium. And then you just slowly try to find that. And going forward or backwards with the catheter in order to lift it up or bring it down. And you can do some small torsions. Try to look for exactly where you want to cross. If that doesn't work, I often go to an RAO caudal projection. And again, with the pigtail sitting in the bottom of the non-coronary cusp, I know I need to search very close to that, because this is where you have an overlap of the left and the right cusp, and you have isolated the non-coronary cusp on the one side. So if you search close to that pigtail, will often give you. But again, it's a try and error. As I said, this is the 2 catheter I'm used, and also I used a standard straight guide wire because it's going to give you a little bit more support. If it doesn't succeed, I will try to take a hydrophilic wire, which is sometimes will solve the issue, but it's also more flexible, so the jet may push that wire aside.
Correct. And when you cross it and you cross a very stenosed valve, sometimes that wire does not give enough support for your catheter to cross as well. So
Yeah.
you're right. I think these are the steps we would go through, including rotation of the catheter from the non-coronary cusp towards the coronary cusp, towards the right and left. And that's when you actually sometimes hit the valve. But you're right. I also use a metallic straight wire, which provides a better step of support in going through the valve than a very slippery wire, which we keep as a second wire in case the first wire doesn't cross. Are there any other questions from the
Dr. Hazra,
panelists? Yes, Dr. Hazra.
Once you have LVOT calcifications and large calcified cusp, that can cause complications. So what do you think in the future? Should you pre-treat them with extravascular lithotripsy, what the Dutch group is doing and have presented many cases in Europecia last year, and then you go for a TAVR, or it's not a problem with the modern TAVR genetic, modern TAVR valve system?
I would say we have no evidence that lithotripsy is going to work in these patients. It may be, but we have to see more data on that. I would say, first of all, you have to be cautious about this. If you have severe calcification extending down to the left ventricular outflow tract, I would probably go for self-expanding technology, because a balloon expandable technology, you need to oversize it somewhat, and that will increase the risk of annulus rupture. Balloon expandable technique is more forgiven as long as you're careful with your balloon you use for pre and post dilatation. So try to stay within the minor axis of the aortic valve. And again, remember, the first talk we saw today was a great talk, and we saw the great data from the low-risk trials, particularly the PARTNER 3 trial with the low-risk patients. But remember, these patients were highly selected. Patient with severe calcification of the left of the aortic annulus was excluded. Patient with any calcium in the left ventricular outflow tract was excluded. So just keep that in mind. If you want to have excellent outcome, you also have to select your patient very carefully.
Thank you.
Thank you very much, Lars. And I also appreciate the fact that you presented the step-by-step with the Indian innovation, which we're very proud of. Thank you. Thank you, Lars. We should move on, and maybe we may have time at the end for discussions. Our next talk is by Dr. Praveen Chandra on the choice of valves for transcatheter aortic valve replacement. Over to you, Praveen. And of course, in India, we now have a choice of 4 valves and soon to be 5. So it's a very important subject, I would say. Praveen, are you there?
Yeah, I'm sorry. I was just struggling. What's happening? Okay, fine. All right. So thank you very much for this fantastic session. And I heard Dr. Lars talk, and this was something, after this, you can't give a talk. that's the whole problem. But anyhow, I have to, and so I have to share my talk now very quickly before I start wasting more time. And okay, right. So basically today, the choice is that, which patient has to be treated and which valve has to be given to that patient, because we have 3 types of valves, at least in India as of now. And the 2 more are coming in, and they will be available very soon. They are actually available now. So we have now 5 types of valves. So now the question is which type of valve. So basically there are 2 types, basic types of valves, and one is the self-expanding and the other is a balloon expanding valve. Now the question is, which is the right patient, which is the right access, and which is the right valve? These are the 3 basic questions which come to our mind when we are treating a patient with severe aortic stenosis. So this, now everybody is aware that patients can be treated in low surgical risk, intermediate surgical risk as of this data. And now this is the final summary of that, just to show you that you can treat a patient who has severe aortic stenosis after a heart team discussion based on the anatomy and the operator experience and the skill of the operator. So all this is coming into play, and then we can decide whether the patient goes for TAVR or SAVR. So this is the latest updated information on when to use, which patient can be taken for selection for transcatheter valve replacement. And of course, it is not a first choice in many such situations, as you see here, as Dr. Lars has already alluded to, especially the very, very low coronary heights, a very small annulus where there is no valve which is being made as of now, which is in the range of 16 or something like that. And patients with severe aortic regurgitation pure, but still some patients can be treated where there is a failing bioprosthetic heart valve, which comes with a severe aortic regurgitation. And those patients who have associated severe aortic stenosis and also have severe regurgitation, these patients can be treated. And those patients who are very sick, who cannot be treated today, are the ones which are having severe comorbidities, very bad lungs, low, very, very low ejection fraction, and they don't have any reserve. So in these patients we cannot. And of course, extremely frail patients, definitely where the chance of that patient making any useful life is very low, then of course this is not indicated. So and then these patients are taken for a balloon aortic valvuloplasty. So I will now quickly go to those situations where I'll just go for the selection of the valve, because I will not go for the access site discussion, because I don't think that is to be covered now. And I'll go quickly. I'm just skipping some slides, and basically now going to the right valve. So these are the valves which are available, and the difference between the valves is that one is the self-expanding category, and the second is the balloon expandable category. So in balloon expandable, we have the My valve from Merrill and Edwards Sapien S3 valve, which is available in India for a little while now. And the Medtronic Evolute R, the Evolute Pro, the vascular Hydra valve, and now the Portico valve is also going to be available. So as you can see here, that these are supraannular valves, whereas the Hydra and the Portico are annular valves but self-expanding, whereas the these valves which are balloon expandable are annular valves, whereas the valve is situated at the annulus level when they are implanted. So what actually determines? So many things determine. One of the most important is the valve complex, which is the annulus, the sinuses, as you can see here, the ST junction, the height of coronary arteries, and so all this is known as the aortic valve complex, and this determines many, many times that which kind of valve we use, apart from many other variables. So the aortic root is, as you can see here, this is basically, and that's how we really figure it out. And the CT scan, CT imaging, where we measure the, the CT measurements of the LVOT, the sinus of the Valsalva, and the sinotubular junction, all are measured. And based on that, and of course, one of the most important measurements is the annulus, which actually decides that which kind of valve we are going to select. And the device selection criteria of which size of the valve is done is based on the charts which are available from these companies. And here you can do this charting very easily. However, you can also do it by doing oversizing for the self-expanding valves, which is in the range of less than 20% most of the times, and for balloon expandable valves also in the range of about 10% at the most. So this is the way we select these valves, because they come in fixed sizes. So these sizes cannot be changed. And this has to be then matched to the size of the aortic valve complex, which is being treated in that particular patient. So the THV size selection, annulus, and there are borderline sizes also. And the primary goal of when we do the implantation, what is the goal? To maximize the effective orifice area so that we get the best outcomes in that particular patient, reduce the mean and peak pressure gradients, and the larger the valve is, it is better. And all this is depending upon the situations where we can use a valve which can give the best outcomes. So here you can see that the oversizing is about 5 to 10%, which is ideal for balloon expandable valves, but the sizes are not so flexible. So now, of course, with the My valve, the sizes are more flexible. They make more sizes than the S3 valve, as you already know. So I'll just quickly escape. I think the slide has got stuck. And So I will just go to this and come down. So the selection of the size is dependent upon these, the charts, and also as I showed you that the different valve, manufacturers have different sizings, but most of them are in the same range, as you can see. So now I will go to this one. Yeah. So when the annulus is small, as you can see in this particular patient, the annulus is very small because it is a valve and valve situation. Generally, it is preferred to use a self-expanding valve over a balloon expandable valve, because if we put a balloon expandable valve here, it will work fine. But the gradients which we will get in this patient will be higher. So that is why we tend to use a self-expanding valve in these situations. Then the second very important thing many times is the type of calcium. And as you can see in this particular patient, that the calcium, there is a spur of a calcium, which can sometimes, if we go with balloon expandable valves, it can lead to perforations because the raphe is very heavily calcified. So that is something which we see in bicuspid valves, and it was very common then to use a self-expanding valve because the chance of rupturing is lesser in this kind of situation. Then STJ calcification, if it is too much, and if the valve is going to going to expand there, it can lead to rupture in those situations. LVOT calcium, if the LVOT calcium is too high, although many times even we do now small LVOT calciums, or if it is not too much with a balloon expandable valve, but if the LVOT is calcified, then a self-expanding valve is better. Then, of course, if it is a very, very heavy calcification, then also the outcomes are not so good. And in these situations, I'm sure we'll have some discussion if we have time, but certainly we have to make our selection right, depending upon the amount and distribution of calcium, because it can sometimes lead to occurrence of a paravalvular leak in these patients. So if the LVOT calcium is there, as you can see here, this patient has LVOT calcium, and in this patient, if we use a balloon expandable valve, it may not be a good idea. It can be better off with a self-expanding valve. So that is how we decide. And then, of course, as you can see here, this is a patient where we have done a self-expanding valve, as you can see here, because the calcification was there, a very heavy calcification though, but initially this valve didn't expand so well, but after balloon dilatation inside the valve, we were able to expand the valve very well. So valve selection, as I told you already, depends upon one of the factors is calcium also. Then acute angulation and the horizontality of the aorta is also something which is important. As you can see here, that in a patient which has very horizontal aorta, the coaxiality of the valve is something which does play a role in the outcomes. And here you can see that in these patients who have horizontal aorta, of course you can do with a balloon self-expanding valve, but balloon expandable valves are better because they are self-centering valves, and they are better off in this horizontal aortas, extremely horizontal aortas. Then risk of coronary occlusion, it is independent of valve type. It is dependent on the height of coronary arteries. It is dependent on the length between the annulus and the coronary ostia, and the leaflet length, the movement of the leaflet during balloon valvuloplasty, because these native leaflets actually close the coronary arteries when they are very low. So in these situations, we have to measure the sinus of Valsalva because that's where the blood fills. So the risk of occlusion can be really assessed by that, and then one can select the valve based on what valve will accommodate which size of sinus and which size of coronary arteries. So here you can see that these are the the measurements which are available with the valve companies, and they tell which size of sinus of Valsalva is required for a particular size of valve. For example, for a 26, we definitely need at least 27 or more sinus of Valsalva diameter compared to some patient who has less. So this is how we make the decision in preventing this very serious complication of coronary occlusion. Then going to the coronary access. Now here again, there is an issue that in those patients where coronary access may be an issue in future, or may be an issue because of the age of the patient, because many young patients are opting for TAVR treatment. So in these patients, the coronary access is potentially easier than in the balloon expandable valve than a self-expanding valve. So this is important to select the valve which is a balloon expandable valve in these patients. And of course, the optimal positioning is very important compared to a higher implant in these patients who have low coronary arteries where coronary access is an issue. And certainly, so balloon expandable valve is preferred in younger TAVR candidates where consideration for future coronary access is there. So this is something which we do consider, and of course, not everybody has the same idea, but certainly as a general, understanding that future coronary access is better with balloon expandable valves compared to self-expandable valves. And then, of course, looking at the impact on conduction, there is no significant difference in the impact of conduction, although initially there were more chances of having a pacemaker implantation with a self-expanding valves, which was the core valve, and less with the Sapien XT valve. But now they are almost similar because in both we do high implants to get low incidence of pacemaker implantation. So basically, in more than 80% cases, any of the commonly used valves will do the job well. So basically, one has to develop a habit of doing one valve, technique-wise and experience-wise. It is better to start with one and then, of course, go on based on the anatomy and based on the experience. So the specific anatomies, as I told you already, valve in valve, coronary height, calcification, access of the for the valve implantation, and of course the annulus. But here you look at the data which was published comparing valves, and they showed no significant difference in terms of all-cause mortality and cardiovascular mortality comparing balloon expandable valves and the self-expandable valves over a period of 5 years. So this was something which is very important, that overall there is no big difference in terms of bioprosthetic valve dysfunction. Also, again, there was no significant difference. So both are, both types of valves are equally biostable in long-term basis. And this is basically the comparison of newer generation self-expandable valve versus balloon expandable valves. And here you can see that there is a small difference, although not too much, in terms of the primary endpoint. The p-values are very not so much different, and certainly in terms of occurrence of stroke, there was a slightly higher chance in the balloon expandable valves, but overall the PVL was higher in the the self-expanding valves. So in total, there is a balance between these two types of valves. The
Time
PVL
over. Time over.
rates,
Sorry, time over.
okay. So
Praveen, your time is
so now for the
running
valve
out.
and valve situations like the mitral valve, there is no choice. You have to only use a balloon expandable valve, as you can see here in this particular case. So in to summarize, now this is the final summary which I have made it just collecting all this information, that if the valve annulus is small, then basically self-expanding valve is better. If the vessel size is small, then of course, if it is less than 5, then none of them are good. But if it is between 5 to 6, one can use a inline sheath with a self-expanding valve. But if it is 6 to 8 or more than 8 axis size, then all the three are similar. If the heavy calcification and low coronary, all are, one has to be very cautious between all the types of valves. If the LVOT calcification is there, then self-expanding is better than the balloon expandable. If there is horizontal aorta, I will say that balloon expandables are better. For conduction disturbances, I can again say that there is some caution here with the self-expanding if there is a baseline RBB, but otherwise they are similar. And for valve in valve, self-expanding is better. And for basically for more sizing, certainly we have more sizing in the my valve, which is the balloon expandable valve. And for future coronary access, balloon expandable valve is better. So this is the final conclusions for my presentation. You must remember that outcome should match with benchmark. And the shared decision making is very important while selecting a TAVR versus SAVR. Reconsider surgical option if the anatomy is not suitable. And of course, the life expectancy of the patient should be considered before doing any TAVR procedures. And tailoring the valve and technique to the patient favors good outcomes. Thank you very much.
Thank you. Thank you very much, Praveen, for that extensive coverage of a very important subject. In the interest of time, I think we should move on to the next talk. CT analysis is a very integral part of planning and execution of a successful TAVR from the days of understanding the valve complex through echocardiogram. CT analysis clearly demonstrated superiority and the right way to go. And therefore, it's not just important to get that analysis, it's important to do the analysis yourself. It avoids complications and it also improves outcomes once you have a clear understanding of the valve complex. For this important talk, we have Dr. Amit Chaurasia to talk about CT analysis as an integral part of planning TAVR.
Thank you, Dr. Seth. We have already listened to a lot of talks, and most of I'm just going to share my slide. And is my slide visible?
Yes, it is.
Thank you so much. Most of my job has been made easy by Dr. Lars, who actually went on to discuss some part of the CT analysis. And after that, we had an excellent talk by Dr. Praveen Chandra, who also explained some part of the CT analysis. But overall, what are the things we are looking at? We are looking at the CT protocol. What is the CT protocol? And what is how do we reconstruct it? How do we analyze the CT report? What is LVOT? What is annulus? What is sinus of Veselva? And what is the STJ? Now, all these things have slightly different meaning in relation to TAVR CT. So I'll be explaining those in a few minutes. When do we anticipate coronary occlusion? And what is aortoventricular angle? Where and when we need some extra information while we do a TAVR. That is, we have to go slightly more than the general, reconstruction of the CT. So the CT protocol, what is the CT protocol that we follow? It should be ECG gated. We use a contrast of 80 to 100 ml and injected at the rate of 4 to 6 ml per second. We use a bolus tracking, and the peak of the contrast should be in the ascending aorta, and this is very important. So you should convey this message to your technician. It should cover from the carotid to the mid-thigh so that we can have analysis of all the possible kind of access that is required for your TAVR procedure. Detector collimation should be at 0.4 to 0.625. The pitch should be adapted to the heart rate, and it should be around 0.2 to 0.43. It should be a sub-millimetric, that is less than a millimeter slice thickness, and the overlap should be 0.4. Smooth to medium reconstruction kernel, and you should take the best systolic phase. Again, I want to repeat, this should be a systolic phase CT, and the reconstruction should be done in a sub-millimetric. So we look at all these things, and I'm going to discuss this in a stepwise manner. So when you do a CT analysis, what you do is first you open up one of the cusp, that is denoted by your coronary, and this is the right coronary which I am showing at present. And then you go to the lowest cusp. You scroll to the lowest cusp, mark that point, just like in this case. You mark it with a red, yellow, or a green. And then similarly, you do for each of the cusp, each of the hinge point. This is what we call it as a hinge point. Now, in a TAVR case, the annulus is actually not the true annulus, but it is the annulus of the hinge point. So it's a virtual annulus. And then when you mark all the three virtual annulus, then you take a closed polygonal point, and then you actually take the diameter. So you will get as in this case, I have just measured the perimeter derived diameter, but you will also get the maximum, minimum, as well as you will get the area derived diameter. Now, what is the importance of all these things? When you are planning your CT, if you want to do a pre-dilatation, you should never exceed your pre-dilatation balloon more than the minimum diameter. Now, if it is 19, you should be less than that. That is, it should be less than this 19. 19 minus 1 is 18. You can take a 18 millimeter balloon. If you take a mean of these diameters, then it will come to something around 23. Now, if you want to do a post-dilatation, always remember not to exceed this diameter of, in the case of while you are choosing the balloon. So it should be, if it is 23, you can take a 22 millimeter balloon. And sometimes you can also go in equal to the diameter. Then you look at where are the calciums situated on the annulus. Like in this case, if the calciums are situated at a particular point, a rounded calcium, then these are the point of cautions, because if you're going to balloon these kind of annulus with a large balloon, then this will act just like a knife, just pierce through the annulus and cause massive pericardial effusion, annular rupture. The second thing is you look at the calcium extending into the LVOT. When you have this kind of calcium that is extending into the LVOT and you use a larger balloon to pre-dilate this kind of valve, then the annulus calcium is going to rupture, and that rupture is going to go linearly into the LVOT. So the linear rupture is more dangerous than just a single point rupture. A single point rupture, actually you can use another valve to just seal off the rupture, but here it becomes really difficult to seal off the rupture. After you get the various kind of size available, then you can size the valve, what kind of valve you are choosing. When you are choosing a self-expandable valve, then it is the perimeter derived diameter that is more important. But when you are looking at a balloon expandable valve, then it's the area derived diameter that is more important. And depending upon those diameter, you can choose your valve, depending upon the chart, as Dr. Chandra had also explained. What is LVOT in the case of TAVR? Now, LVOT, we usually understand that it is the area just below the annulus. But here, when we measure the LVOT in the case of TAVR, we measure the LVOT 4 millimeter below the hinge point. So there we go, and then we take a circular measurement, and that is our LVOT. And again, in the LVOT, you'll have to see where the calcium is. If the calcium is a circular kind of calcium, then it should ring in your mind, if it is a circular kind of calcium, that I'm not going to use a larger balloon. I'm going to use a self-expandable balloon, a self-expandable valve. And after I place my valve, I should also keep in mind that there is a chance that the valve may slip up by 1 or 2 millimeter. So all these things you will have to keep in mind, particularly when the LVOT size is less than the size of the annulus. Now we know that this is the annulus, 4 millimeter below is the LVOT. The sinus of Veselva, we take the largest diameter that is there over here. And then we measure the height of the coronaries. We measure the height of the STJ. This is the STJ, that is the sinotubular junction. And also we measure the diameter at the sinotubular junction. Now, when we are analyzing the sinus of Veselva, it is very important again to see what kind of valve you are dealing with. You're dealing with a bicuspid valve or you are dealing with a tricuspid valve. This is particularly seen in the sinus of Veselva because it's the place where the leaflet actually opens up. Now, this is clearly a tricuspid valve. Now, you should also look at if the calcium is circular or something like that. This is the sinotubular junction, diameter of sinotubular junction, and we should measure this diameter because of certain reason, which I'll come in my further slides. The height of the coronary is then you measure from the hinge point to the height, and this should be more than 10 millimeter at present. Then you look at the height of this STJ. Now, different valves have a different diameter. It is not possible to actually talk about all the valves in a single talk. So what I'll do is I'm going to talk about Medtronic valves, but this is also this can also be extrapolated to the balloon expandable valve. So we have talked about the annulus, we have talked about the LVOT. the sinus of vessel diameter should be at least 2 millimeter more than the size of the valve you are using. So if you're using 23 millimeter valve, it should be at least 25. If you're using 26 millimeter valve, then it should be at least 27 or 28. If you're using a 29 millimeter valve, then now the size doesn't matter much. It is either 29 or 30, but if you're using a 34, then it is 31. Now, 34 millimeter valve, actually the diameter is 34 only onto the top two, and then the rest of the studs, it behaves just like a 29 millimeter valve. So if you're going to implant a 34 millimeter valve, it is better to implant slightly keeping the depth in mind that it should not exceed more than 5 millimeter. Otherwise, it tends to behave just like a annular valve. Now, if we see, we have the coronaries over here, we have the leaflets over here, and we have the skirt ending over here. Now, height of the coronary, this skirt over here ends at 13.5 millimeter. If we are going to implant 3 to 5 millimeter, we have a cushion. If we take 10 millimeter height of the coronaries, then we have a cushion that we are not going to close the coronary because of this skirt. This is only one point. Now, if you see, if this sinus of vessel diameter is very large and not narrow, then still the blood can flow in the diastole in this kind of arteries. Now, if you have what is called STZ height that is very large, then also the coronary is not going to close. Finally, if you have a calcium at this leaflet tip, you should keep in mind that when you place the valve, that due to Venturi effect, while these coronaries are filling, this leaflet can fall back and close the coronaries. So you should also keep in mind that if you have a heavy calcification, it is better to measure the leaflet length if your coronary height is low. Now, if you are doing a valve in a valve position,
you'll have to.
I thought the presentation was for 12 minutes. That is
I don't
how
know.
I prepared
It shows on the clock on at one more than.
Okay, I'll just try to
1.5 minutes past
okay.
your time. The clock shows that.
Okay, so if you are doing with a valve in a valve, then you need to look at whether it is stented. The leaflet is out of the stented pole or inside the stented pole. And then you need to look at the VTC, which is valve to coronary distance. And if this VTC is more than 4 millimeter, then you can actually avoid the coronary occlusion. The third thing is you need to look at the calcium where it is. If you have a calcium around this point, then you should think about the neuroprotection in this kind of patients. And if you have a lot of tortuosity, then you need to think about actually how you are going to transverse that. This was a case in which this portion, it was severely calcified and I could not cross over with the valve. I thought it could easily go over because it was 5 millimeter, but I tried to balloon it with an 8 millimeter, could not. I didn't have an IVL, so I ended up putting through the subclavian. Now, the femoral, you should be careful to look at where the calcium is and where if you are going to take a puncture in this side, then it should be a clean puncture because you have calcium at the posterior surface. If you end up needling over here, then you can end up, your proglide may give up, or you can end up closing the valve, closing the iliacs. Finally, if you look at the aortoiliac angle.
You have only 30 seconds time to wind up, please.
Yeah, we look at the aortoiliac angle, and if this angle is between 30 to 50, it is the most appropriate angle to implant a valve. If it is 30 to 50, then 50 to 60, then it is mildly difficult. Above 60, it becomes difficult. Finally, I would like to conclude by saying planning is the key. All aspects of complications should be discussed with the patient. Small tricks may help, and that is well denoted in the CT itself. Keep everything ready to tackle any kind of complication. Finally, I would like to end. TAVI or TAVR is 99% planning and it is only 1% execution. So you should do your CT yourself, try to minimize the complication yourself, keep everything in mind from the CT before you go into the case. That is the key to doing any kind of TAVR procedure. Thank you so much.
Anjanda, please introduce Dr. Seth, next speaker.
Yeah, so I'll just share my slides.
Anjanda, can you do?
Dr. Ashok Sheth does not require any introductions. We don't need any want to waste any time to introduce him because he is well known in India and abroad, and is one of the pioneer of interventional cardiologists in India. He has
Thank you.
switched over from coronary to non-coronary.
So, so I'll just share my screen. Let's see. There we-
Amit, you have to stop sharing. You can see your slides, sir.
Yeah, can you see my slides? Yeah. So I'm just going to, I'll just put my timer on so that I can be well in time. Okay. So we're going to discuss the complications of TAVR, just to understand that there are 5 big, very procedural complications that we get concerned about, which is stroke, paravalvular leak. Of course, these are elderly patients and are more prone to acute kidney injury. We've got to be very wary of how much contrast we use. We've had discussions around heart blocks and the requirement for a temporary pacemaker to varying degrees amongst various reports and trials. And of course, large bore access is what we do, and therefore we're very wary and have to take all the precautions regarding bleeding complications in the elderly, which can be fatal. As far as the hemodynamic complications of the valves concerned, we need to understand that we traversing diseased aortas in the elderly. They can be tortuous, calcified, can be hostile, and the same goes for every part of the vascular tree, right from the femorals to the aortic arch and up to the valve. So aortic dissections of the ascending aorta of the thoracic aorta can actually occur in such situations. Coronary occlusions, we've just discussed that. The height of the coronary arteries is a very important feature, as is the whole valve complex, including sinuses, which dictates coronary occlusion. Of course, there's all the issues around working in the left ventricular cavity with perforations and tamponades. So if you look at this data, what it tells you is the complication rates in the various trials. And let's just go to the SAPIEN 3, which was the latest. And then, of course, we have the low-risk trials. But the SAPIEN 3, which was a lower profile valve, and by that time, enough experience had been achieved, and the techniques had been modified for safety, the all-cause mortality, and this is intermediate risk patients, the all-cause mortality is somewhere between 1 to 2%. Disabling strokes are somewhere between 1 to 2%. Paravalvular, moderate paravalvular leaks range between 4 to 5%. Major vascular complications are in the range of 6 to 7%. And again, this is to be very important. We'll go through some of them. Life-threatening bleeds, again, an important aspect to be taken care of, around 5%. So vascular complications still remain an important aspect of TAVR. Acute kidney injury has to be taken care of, and of course, with precautions can go down really low, because this often at times we don't need to use much contrast. And we have, of course, permanent pacemaker implantations depending upon balloon expandable versus self-expandable valve, ranging from practically 6% as high as 35% in some of the reports. So when we go across all this, I want to see that if we talk about the low-risk patients, of course, the complications are lower in the low-risk patients, and compared to surgery, as far as these complications are concerned, we can see that it favors TAVR instead of SAVR. Most of the complications are lower in low-risk patients in transcatheter valve replacements. Now let's start from the basics. And one of the basics around this is that this is large bore access. You just saw last tell that you go from the contralateral side over across the bifurcation into the ipsilateral side, inject the contrast either through a pigtail, and then puncture this artery with a micropuncture needle. Once you micropuncture, then it's time to put the proglides in, which is a pre-close of this femoral ipsilateral femoral artery. And this can happen. This is a reality. You can leave the pigtail there, or you can bleed something out there. the one which you've used to inject from the other side, contralateral side, cross over into the ipsilateral side, and we've actually pre-closed the pigtail out here. So it's very important to pull back the catheter you've used to give you the guide injections before pre-closure. Otherwise, you can actually stitch the pigtail, as in this case. And then, of course, we had to gently release that pigtail through various maneuvers by cutting the proglides in and then putting other proglides. So this is important. Take it out. Simple, but important. Well, here's another important aspect. This is a situation where this lady, bicuspid valve, TAVR was done using the 26 evolute. And then as we're coming out, you can see the very poor flow down that. This is before it's been taken out, before the valve has been taken out from the left side. And of course, as soon as this was taken out, there was no gush of blood. And soon we realized that after we closed it, that there was absolutely no femoral pulse felt. And this was quite clear. Contralateral injection on the from the contralateral side across the bifurcation showed occlusion, thrombus formation due to drop in ACT. We reverse the ACT towards the at the end. And often at times, occasionally, you can actually have a dissection out there which would close off this vessel, creating thrombus formation. So both these actually, and therefore the easiest way to treat this is low pressure balloon dilatation across the femorals using a 4 to 5 millimeter balloon. This is what you see on the left side coming from the contralateral side. The flow is restored, heparinize the patient for the next 24 hours. Flow leads to resolution of thrombus. We actually then talk about further thrombus formation, non-axis vessel. Again, you see we have at the end, remember these are large sheets, they have empty spaces. If we don't keep flushing them, and if we don't keep the ACT up, these 14 French sheets will develop thrombus in the areas with the gap between the shaft of the valve, which is 8 French versus the 14 French sheets. So that's got to be flushed regularly. Here at the end of the procedure, this is the procedure is done from the left side, which is contralateral. As we take the sheath out, normally we put the dilator of the sheath in. We actually stuff out thrombus, and therefore when you see this on the right side, you would see that there is suddenly, let's see whether this runs. Okay, maybe the next one will run, and we'll show you that on the right side is a total occlusion. There's a lot of thrombus sitting there, which has been flushed out of the sheath, which was taken out from the left side. Here it is. It's really floating thrombus. So management of this thrombus could be either suction it out, or put an absolute pro or self-expanding peripheral stent, which goes through a 6 French sheath easily. And then you have a restoration of flow, as you can see here, and good flow down. Just heparinize them for overnight heparinization, restores flow, and the patient as well. Be wary of this thrombus formation. Keep the ACT up, keep the large bore sheets flushed. Significant paravalvular leak does occur in these in many patients, especially in the bicuspid valve patients. If there's heavy calcification, heavy eccentric calcification, this and inadequate predilatations. Here is this. You see that here, significant paravalvular leak on the aortogram as well as on the echo. And that's primarily because you can see that in the other view, it looked as if the valve had expanded, but on the RO projection, you can actually see the valve not expanded due to indentation through a heavy calcified leaflet. This is, of course, managed by post-dilatation at rapid pacing. Its malapposition gets corrected, as can be seen in the next view. And here you see the malapposition corrected and the resolution of paravalvular leak and restoration of gradients. Severe paravalvular leak can be actually, the entire device may be constrained rather than the leaflet. That happens quite often at bicuspid valves. That's why pre-dilatation of the bicuspid valves is often advised, and it's our recommendation that we do it all the time. And here is that situation where you can see the whole constraint of the valve itself, and then this requires a post-dilatation at a rapid pacing, and final shoot shows no paravalvular leak. Again, you can see what has happened on the left side. There's a gradient as well as paravalvular leak. There's the low diastolic pressures which are resolved on the right side. You can actually have deep implantations, as can be seen on the left side. The valve slips in This is a self-expandable valve which slips in, causing severe aortic regurgitation. Of course, this patient has the risk of going both into ventricular arrhythmias as well as pulmonary edema on the table with this and hypertension. Of course, this cannot be corrected by any other methodology. Post-dilatation does not correct it. A second valve has to be implanted, therefore, slightly higher than the first valve, and that results in the resolution of the paravalvular leak. And then there's good result at the end, and the patient, the blood pressure gradually comes up. You can have extensive vascular complications. I mean, this is, you heard about the fact that balloon expandable valves require a minimum of 6 millimeter of iliac size or vascular size to go through. You may have a borderline vessels. The sheets which come are the 14 French the 14 French expandable sheets, the E sheets, are lubricated and are easy, well, when pushed in, may actually cross to even a 5.9 millimeter vessel and can be slowly pushed upwards. But we must remember that they're very difficult to withdraw in borderline situations, because by that time there would be spasm of iliacs. The patient would be awake, he's had a procedure, the patient would be tense and anxious, and the vessel closes up on the sheath, as it happens in the radials as well. And this is one of those such situations where sequential dilators allowed us to get this E sheath in a 5.8 millimeter vessel, just enough to stretch it, but then, and we finally got the sheath up, we dilated at multiple places. And so just getting the sheath up and doing the case is not the real issue. Having got all this up, after that, this is what happens when we try and get it out. The sheath would not come out. Suddenly there was a give. A give, when you pull a sheath, means that you've actually transected the iliac. The iliac got avulsed. We normally have our wire there. We therefore normally put our dilator through the sheath, and therefore we push it up. And once we push it up, we've at least partially tamponated the rupture of the vessel. You can see that this is a really bad rupture of the iliac. A covered stent is put in, a second covered stent is put in, and by the way, covered stent is put in usually with an aortic occlusion balloon, the coda balloon, right up in the aorta, which stops flow down into the vessels, and you can work on the vessels. We now have a coda balloon parked in the right coronary artery above the leaking side, because we just could not close this. And we were able to shift the patient with one coda balloon up in the aorta, one balloon in the iliac, and the patient was not bleeding anymore. The artery was transected, and we shifted this patient up, and therefore this is what the patient had: a surgery performed, all that removed, a bypass done, and the patient survived and did very well. Finally, and I'll just go to the final. This is important, and I think this is a degenerated bioprosthetic valve. This is never dilate the degenerated bioprosthetic valve. Just go ahead and implant it. I see myself at 12 minutes. Just give me 30 more seconds. In this case, very tight stenosis. The patient was in failure. We did a pre-dilatation of this bioprosthetic valve, which was severely stenosed. And lo and behold, immediately the patient went into standstill. Soon after that, he went into intractable ventricular arrhythmias. As you can see, ventricular fibrillation, absolutely lost his pressure, incessant storm, numerous shocks, could not get this patient out. And therefore, nothing was working for him. This was absolutely a crash on the table. We inserted an ECMO, which we're very good at. I must say, we have a really good ECMO resuscitation team all the time. All of us can put this ECMO, and Vishal Rastogi heads this. 5 to 7 minutes, the ECMO was into the patient. Absolute standstill, zero cardiac output. We could not differentiate the cause, whether it was perforation of the LV, whether it was occlusion of the aortic vessels, which is known complication of implantation of a valve-in-valve. And the CPR was continued. We checked the loading valve, which should have been done earlier. And during the cardiac arrest situation, the only way you can get these patients out is implant the new valve in. And as the CPR was continued, the Evolute 26 millimeter was implanted in a standstill heart unsheathing. You can see on the right side, it's a standstill heart. This patient already had plates of spinal surgery. It was very difficult to see how to position it accurately, but we did manage to position the valve during all that cardiac resuscitation while the patient was on ECMO. Well, 30 seconds, the return of spontaneous circulation returned back on ECMO support. And finally, we started seeing some degree of movement of the heart. We actually injected into the LV. There was no perforation. We looked at the aortic arteries, and the coronary arteries were fine. And therefore, subsequently, from that severe acidosis, over the periods of hours, the patient improved, and with over multiple, in the next few days, as the vital organs recovered from the hypoperfusion of a 30-minute of a return to spontaneous circulation of ventricular fibrillation. Overnight, over a few days, with multiple units of blood and cooperation amongst various specialties, the severe acidosis normalized in the next 48 hours. And a week later, the patient actually went home alive and well, doing great, and continues to do great 2 years from that. So I think all I've got to say is that we've got to prepare for the worst. We've got to have a team of experts working together, and we've got to pre-plan every case to anticipate complications, which is not always possible, but to be able to treat and deal with complications, which with experience, expertise, planning, and coordination and cooperation of multiple specialists is feasible to save lives. Thank you very much for your attention.
That was
Thank you, Ashok,
yeah,
for giving us an extreme complicated scenario at one end, and how a team of heart conjointly can fight it out and save the lives of patient in the background of such a serious complications. Dilip, do you have time for discussions?
I think we are running short of time.
I'll have just one questions to make. In SAPIEN 3 trial and other trials, there has been an incidence of 8 to 10% of complete heart block requiring permanent pacemaker implantations.
Absolutely.
If a patient before TAVI has a history of symptomatic bradyarrhythmia, do you advise to have the patient permanent pacemaker implantation before going for TAVI?
You see, symptomatic bradyarrhythmia is anyway an indication for a permanent pacemaker implantation. So that's quite clear. I think the worst patients who we predict would happen is patients with trivascular block, right from the branch got their PR interval, will invariably most likely end up with a complete heart block on the table and will require a permanent pacemaker implantation. It's not wrong to advise them. They're going to need it anyway.
The second question is, what is the program of anticoagulation and antiplatelets following TAVI?
It's very clear now. While earlier we started off with dual antiplatelet therapy, we are very clear that single antiplatelet therapy based on recent trial data is as good and decreases bleeding risk.
And mostly advise aspirin.
Aspirin, absolutely.
Dr. Seth, one suggestion in your last case, I think you are the father figure of TAVR and many structural heart disease in India. Why don't you have a Lucas system, a mechanical CPR, to have a protection on your hand, and you can carry on your work on Lucas system?
Yes, it's a very good system. We actually had it for a duration of time, but I don't think that Lucas is available anymore. So we actually had it in our lab for 6 months. We actually used to get our patients of primary PCI or cardiac arrest who for primary PCI from the ER and have used it. Efficient system. It allows us to actually do the procedures well. But the Lucas actually withdrew that system. We had it on, and then ours malfunctioned, and we couldn't get a second system in.
Okay, so Dr. Chanda, you have democratically placed all the valves. Are you there with us? And out of 13 points, you have given 2 red hands to the MyValve, 4 red hands to your SAPIEN, 5 red hands to your Evolutar, 2 YOLO for. So ultimately, you don't answer me a democratic choice like everybody is born equal, so everybody is good, and one size does not fit all. But from your chart, it seems that you have given a winning title to MyValve. So what's your comment on that?
Dr. Hajra,
yeah, that is the last.
I've been instructed by the organizer to call it a day for the time being, and all good things should come to an end. With a brief comment from Dr. Praveen, we'll call it a day for this session.
You know, basically, as I was presenting, that all valves are almost similar, 80% times. So there is no, one valve which is better than the other one, both in terms of evidence and also in terms of experience. You have to really choose your valve based on the anatomy and based on the clinical features of that particular patient and based on the access. So there are multiple things which we have to assess, but otherwise overall outcomes in short term and long term are equal.
Thank you very much. Thank you all very much for being so active and vibrant and giving us new insights, valuable insights into the structural heart disease problem of this particular type, that is TAVI. And thank you very much. We now hand over the mics to our organizer.